All right, so good afternoon, everybody, and welcome to this important webinar on gender equality and health organized by the Infectious Disease Alliance. My name is Ellie Jongever, and I am the committee manager for our Gender Equality and Health Committee, and I'm honored to be your host today. We have an outstanding lineup of speakers who will share their expertise. Firstly, Rodrigo Scottini, our executive director, will give an introduction to the IDA. Next, Dr. Jessica Ogden will discuss vulnerability as strength in a global health context. Then Kinza Hassan will provide some insights into gender-responsive universal healthcare coverage. And then if you notice, one of our originally listed keynote speakers, Lisa Gorlitz, she unfortunately was unable to join us today due to illness, but we wish her a swift recovery, and we hope to welcome her at a future IDA event. In the meantime, we will proceed directly to our panel discussion following Kinza's presentation. And then this panel discussion featuring experts on gender equality and global health will involve discussions on current priorities in global health, strategies to address gender determinants of health, and ways in which organizations can promote gender equity in the long term. And then after this panel discussion, we will have a question and answer session where the attendees will have an opportunity to engage with our experts and ask any lingering questions. Each key speaker has 10 minutes for their presentation, and the panel discussion will be about 30 minutes long. But if you have questions in the meantime, you can write it in the chat, or you can raise your hand on the raise hand function during the Q&A session, and I'll be happy to share it there. So thank you so much for joining us in this important conversation, and let's get started. So first, I'd like to welcome Rodrigo Scottini, IDA's Executive Director, to say a few words about IDA in general and the importance of gender equality and health. Over to you.
Thanks, Ella. Good afternoon, everyone. My name is Rodrigo Scottini. I'm the Executive Director of IDA. Thanks for attending this webinar today with us. So IDA is the Infectious Diseases Alliance, and we highly we'll focus our work as well on gender equality. So infectious diseases do not affect people equally. Across the world, women and girls face unique health risks shaped by social, economic, and systems inequalities. Gender norms, caregiving roles, and barriers to healthcare access leave women and girls disproportionately vulnerable, not only to infections, but also to delayed diagnosis, treatment disparities, and exclusion from critical research and policy decisions. Those challenges demand an urgent action. In IDA, we recognize that advancing global health requires integrating a gender lens to infectious disease response. This means that acknowledging the way in which gender inequalities drives health disparities and ensuring that policies, programs, and fundraising priorities reflect the realities of those most affected. In today's discussion, we will explore those themes and highlight actionable solutions for a more equitable and effective global health response. We are privileged to have an esteemed panel of experts, each bridging invaluable perspectives on how to rethink vulnerability, challenge systemic inequalities, and drive meaningful change. So thanks for being here today. I will look forward to our collaboration. So before giving the word back to Ed, I think there's still some minutes left in my introduction. I would like to tell a bit more about the IDA. For many of you, it's a new organization. And so here, I'm going to share my screen. Here we go. So IDA is a global organization representing civil society in the infectious disease space. We highly focus on reducing the burden and improve access to healthcare. And our mission is to unite civil society organizations. We advocate for impactful policies of sustainable finance, unite civil society to combat infectious diseases, promoting healthcare system strengthening, fostering cross-sector collaboration, and promoting equity. What we offer for our members: access to critical tools, opportunities for global alignment, advocacy and policy support, partnership building, and resources. We propose like a joint representation of civil society organizations in the infectious disease space, unifying the fragmented infectious disease community. bringing accountability to policymakers, and promoting exchange, knowledge sharing, and collaboration, which is a very important aspect of our work across sectors. Our members are civil society organizations. We have, so for the members, you can get a representation in the committee. We have a gender committee. So for you present here today, so not only the speakers, the participants, if you are from civil society organizations with a focus on gender, we have a space where you can discuss gender policies and actions and advocacy in this space. So feel free to come back to us regarding possible membership and interest in joining this committee. You get participation in organizing and driving events, alliance updates, advocacy influence. You can share your updates with the community and so on. So number 12 is our committee here in the list regarding gender equality, which is of course a very important aspect of our work. Here we have a series of events we are planning for this year as a IDA. We have the one here on the 10th of April, the gender equality one. We also have other events, so please feel free to connect and register for other events we're organizing. Those are face-to-face in Geneva, Brussels, or Berlin and New York, happening this year. Then you have the webinars, including this one today. Have some still like 5 to come in this semester, so stay connected if there's any you find interesting. So we have gender on the 20th, climate change on the 28th of April, and then HIV, respiratory, primary healthcare, and AI for the rest of the semester. So that's our team, 14 individuals around the world. You can also see on the website, and our strategy of 30 pages publication on the website. So I'll give the word back to Ella, and looking forward to listening to all speakers. Thanks, Ella.
Great, thank you so much. Let me just flip this. All right. So now I would like to introduce our first speaker, Dr. Jessica Ogden. She is a senior technical specialist at the International Center for Research on Women, and she will be discussing how to reframe vulnerability as strength in a public health context. So over to you, Jess.
So much. Can you all hear me?
Yes.
Thank you. Yeah, okay. Thank you to the IDA for the kind invitation to join you all here today, and to all of you for being here at this very poignant time for those of us who care about the health of women and girls and all their diversity around the world. So when I originally agreed to give this talk about 6 months ago, the world looked very different. We knew there was precarity, but I don't think even the most pessimistic of prognosticators could have anticipated the near complete withdrawal of the United States from its responsibilities for supporting the health of the global public. At that time, I hoped to share something with you that would offer a reframing of the concept of vulnerability in the context of gender and public health. Current events have offered a new landscape in which to consider what vulnerability means in this moment. First, next slide, please. So the AIDS pandemic was a different crisis that also demanded of us a reframe. As some of you may remember, AIDS exposed the weaknesses of the simplistic and binary concept of risk that had long dominated public health practice. Risk, during the height of the AIDS crisis, was reframed to vulnerability, a paradigm shift that, at least in some circles, shifted attention away from a focus on individual and interpersonal behaviors to the social, economic, and environmental factors that affect a person or a community's likelihood of being exposed to illness, to having access to prevention technologies and the ability and willingness to use them, and the availability of testing, treatment, care, and support. Next slide, please, Ella. This reframing gave rise to new frameworks for action, such as the social determinants of health framework and structural approaches to public health. And for those interested specifically in addressing gendered health disparities, the emergence of the gender integration continuum. So I'm sure most of you are familiar with the continuum, or at least its language. We're using it a lot here already. But because this meeting is interested in a gender transformative approach to women's health, I thought it would be useful to take a brief look at a key pitfall in the application of the continuum in global public health and why these lessons are important right now. Next slide, please. In her 2021 think piece for UN University, my friend and colleague Anju Malhotra offers a measured critique of the ways in which the concept of gender transformation has been applied in public health practice. Her paper points out, and many of us have seen for ourselves, that public health interventions attempting to be gender transformative typically focus not on the gender power dynamics and biases that exist within health systems, but on the people using the health systems. This, of course, is how much of public health practice unfolded in the era of social and behavioral change. As practitioners, the assumption is typically that the services on offer are right, and that the job of the practitioner is to get people to use them. In research that colleagues and I undertook on the rollout of DOTS in India in the 1990s, we tried to flip this. We took aim at the core programmatic element of DOT and showed that the way the policy and program were transferred down from WHO in India's National TB Control Program, the RNTCP, inadvertently but demonstrably encouraged frontline healthcare workers to exclude the most vulnerable because they were the most likely to struggle with adhering to the DOT requirement of the program. When we shared these findings and recommended alternative approaches, we received strong pushback from the folks at WHO who sat within the RNTCP. The architects of DOTS were terrified of losing control of the drugs because of the very real risk of the program producing massive outbreaks of multi-drug resistant disease. They fundamentally lacked trust in the population of ordinary people suffering from a debilitating condition to be responsible for their own and their community's care. So that was nearly 30 years ago. And over time, DOTS has evolved to get the drugs closer to the people that need them, changes that mostly resulted from patient and community advocacy and activism. No one ever tried to claim that DOTS was gender transformative. On the contrary, in fact, in those days, most TB docs refused to admit that gender played any role in TB control. My point here is that health systems are inherently averse to change, and patriarchy is inherently averse to giving women more access to power and resources. But the responsibility for transforming gender norms and equalizing the health playing field for women and other marginalized people cannot rest solely with those very same women and marginalized people. As Anju points out in her think piece, the injunction to produce gender transformative health interventions has often led to health workers trying to implement microfinance programs, savings clubs, skills building, rather than addressing gender biases in health systems or poor quality and costly services for women at the margins. Next slide, please, Ella. In practice, she says, a disproportionate focus on changing hearts and minds, but not services and quality, can leave women in poor health without the very agency that interventions aimed at empowerment and changing norms hope to foster. We need to refocus efforts on the systems themselves. And clearly, I don't have to persuade any of you of that. But we need to remember that the systems are us. And so here's the good news. Change is happening. I have the next slide, please. WHO has a new initiative that recognizes that, to quote their website, well-functioning health systems are the foundation of gender equality. They go on to state that when healthcare is accessible, equitable, and responsive, women and girls in all their diversity can live healthier lives and have equal opportunities beyond health. They've launched an effort around developing gender-responsive health systems, and I know we're going to talk about that a little bit later, by bolstering the participation of women in the paid health workforce, among other systems changes. Organizations like Women Lift Health are emerging to expand the power and influence of women in global health and to train and cultivate more women leaders in the sector. And while we know that just having women in leadership doesn't in and of itself topple the patriarchy, we also know that diverse systems function better, and women in all their diversity bring unique and particular sets of skills to leadership when they're allowed to hold those spaces authentically. So now for the not so good change. Next slide, Ella. Every person in this room is aware that the United States government is withdrawing from the global health stage, pulling essential funding unilaterally from the WHO and governments around the world without working with those governments, other bilateral donors or philanthropy to put other resources in place to avoid catastrophic consequences. And this is not to mention the sweeping tariffs imposed last week, which will cripple economies and health systems all around the world, including our own here in the United States, where I am. In this context, it seems almost quaint to be talking about gender equity until we remember that while all people will be affected by these changes, women will be affected the most. That is particularly true in light of the concomitant sweeping cancellation of research grants and contracts that specifically focus on the health of women and other socially marginalized people, like those in the LGBTQIA+ communities. And this, of course, is systems change too, but it's systems change away from equity, equality, and well-being. So what to do? Next slide. Now more than ever, the work of the IDA and so many others in bringing us together is critical. We need to, it's critical that leaders in gender and health are committed to the good kind of systems change that brings about greater health among humans, to learn to communicate with one another and co-strategize more effectively. We need to build robust coalitions in which gender expertise enjoys equal positioning with health expertise, to develop, fund, and execute a shared agenda, and to push forward despite the pushback. Such a coalition should seek partnership and collaboration with those working on education and economic development, two other critical legs of the global health table, not trying to do the work of these sectors, but to build alliances, collaboration, and advocacy with experts in those fields. These coalitions can and should likewise partner with feminist funds, grassroots movements, patient advocacy groups, national governments, the private sector, and other concerned and knowledgeable citizens who want to see progress continue. It's time to build connection, create community, and get aligned with one another to fight for what is right. Next slide, please. And this is where I'd like to circle back to vulnerability. Those of us who truly believe that gender equity is a critical pillar of global public health may be in a position of vulnerability right now. But there are several key lessons from folks who study vulnerability through the lens of psychology that can be instructive. This is a reframing of vulnerability as strength. Psychology shows that rather than isolating us, vulnerability, when embraced, deepens connections, enhances resilience, and drives social transformation. Next slide. And we've seen this play out in our sector. During the height of the AIDS pandemic, when activists, patients, and public health experts leveraged their vulnerability as strength, building movements and norm-setting agencies like ACT UP and UNAIDS, it shifted the narrative from individual shame and responsibility to a collective demand for treatment, funding, and policy change. And as a result, global access to antiretroviral therapy increased and public health efforts restructured to get testing, treatment, and care closer to the people that need them. So we are vulnerable right now, and we need to come together in new ways. Next slide, please. Psychology sees connection and vulnerability as deeply linked. Rather than a weakness, vulnerability is increasingly recognized as a pathway to deeper relationships, to psychological well-being and collective strength. Vulnerability fosters trust and deeper human connection. People who allow themselves to be vulnerable in relationships, whether personal, professional, or societal, are more likely to experience meaningful social bonds and emotional support. It can lead to greater empathy and collective problem solving, something vital in this moment. While we often fear showing vulnerability, research suggests that when others express vulnerability, we perceive them as more relatable and courageous. And we need to be courageous in this moment and to see the courage in each other. Sharing our fears about the state of global health in a safe collective context reduces isolation and fosters community healing. And finally, recognizing shared vulnerability in the face of systemic injustice builds collective action. When vulnerability is acknowledged rather than hidden, it can lead to policy change, stronger communities, and greater inclusivity. So here we are in this moment. It's ours to seize together. Thank you.
Great. Thank you so much, Dr. Ogden, for that really inspirational and positive twist on the current outlook. That was really wonderful. So now I have the pleasure of introducing Kinza Hassan. She is our next speaker, and she is a manager of policy and advocacy at Women Deliver. And she will be discussing the gendered burden of infectious disease and gender responsive universal health care. So over to you, Kinza.
Thank you, Ella, and everybody can hear me, right? Great. Good morning, good afternoon, good evening to everyone all over. My name is Kinza Hassan, and I am the Global Health Lead at Women Deliver. As Dr. Ogden had mentioned, this is a very timely discussion given the state of the world, and Just wanted to say that although things may feel stressful, it's important to recognize that we've all come together here to strategize for global health and gender equality. We're up against a lot. Multilateral spaces are threatened, ODA is shrinking, anti-rights movements are spreading myths and disinformation, thwarting populations away from concepts of human rights and the right to health. But how we understand the intersection of gender and health right now and how we communicate it, it's going to deeply impact our post-2030 agenda. So I wanted to take this keynote address to really dive into understanding the importance of gender-responsive universal health coverage, particularly looking at it as a key mechanism to ensuring health for all, but also to address gender inequality in health systems and how we can address the disease burden. Next slide, please. So very quickly, to just give a background on Women Deliver, since we are a small organization, Women Deliver's mission is to protect and promote bodily autonomy for girls, women, and gender diverse people, focusing specifically on their control over their sexual and reproductive health and rights. So we have several different goals in which we do this as an advocacy organization, including transforming global spaces to be more inclusive. So, looking not just at the Women Deliver conferences, but also at global spaces like the CPD, which is happening right now, the UN General Assembly and the World Health Assembly. We also work through coalition and alliances, so to pool technical expertise, to, put our heads together to safeguard bodily autonomy and SRHR. So Women Deliver also co-convenes the Alliance for Gender Equality in UHC and the SRHR Climate Justice Coalition. Also shifting power to young people and adolescents through our Emerging Leaders program. Holding states accountable to their responsibility that they have to fulfill the right to health and the right to SRHR, and advancing progressive narratives on gender and health issues, making sure that they are evidence-based and science-backed in an effort to counter anti-rights movements. And our work focuses specifically on, on adolescent girls, looking at the unique challenges that they face, understanding the interlinkages of climate justice and SRHR, and then of course, countering anti-rights and anti-gender movements. Next slide, please. So I thought it'd be useful before we get into our discussion about, gender responsive UHC, to take stock first to look at the state of gender and SRHR in global health right now. There has been significant progress made over decades. There's no doubt about that, including establishing the Beijing Declaration and Platform for Action, the ICPD Program of Action. These really set the progressive language and standards on the right to health and SRHR that we're seeing today. But they're also under attack. And in recent years, that progress on gender and SRHR has stagnated or slowed. So according to the WHO, the UHC Service Index, the Universal Health Coverage Service Index, increased by only 3 points by 2019, and it stayed that way through 2021. And this essentially indicated that 4.5 billion people were not covered by essential health services. And then according to UNFPA, millions of girls and women remain far behind. Progress has slowed or stalled on key measures. 800 women die every day giving birth, and this has not changed in almost a decade. A quarter of women cannot say no to sex with their partner, and nearly 1 in 10 women cannot make their own decisions about contraception. And in 40% of countries with data, women's bodily autonomy is diminishing. But now we need to understand, why has progress stagnated? We need to understand the context in which we're working in, which Dr. Ogden mentioned in her keynote address. And this is not an exhaustive list, but just to kind of paint a picture, we can start with the COVID-19 pandemic, of course. It disrupted health systems, which has caused ripple effects for years after. It caused delays in many health services, including SRH services. But it's not just the COVID-19 pandemic, it's economic crises, the climate crises, humanitarian crises, which have really exacerbated so many of the challenges that we're seeing today. And it has disproportionately affected women and girls in marginalized communities. The pushback from anti-rights and anti-gender movements have posed a threat and have been posing a threat to our hard-fought gains. The rollback on women and girls' rights, governments are enacting restricting laws and policies, including in the United States, on reproductive health and services. And this undermines gender equality. It worsens barriers to improving health and well-being. And it creates and sustains a cycle of marginalization. The current political climate, deeply fractured. States are reneging on their financial and political commitments. ODA is shrinking. It's negatively impacting global health programs and services. Dr. Ogden mentioned the shuttering of USAID and what kind of impact that will have on global health programs internationally. All this to say that this stagnation it's concerning, and it really signals an urgent need for renewed commitment, stronger political will, greater investment in health systems. Now is the time to invest in gender equality initiatives, invest and design policies that actually empower individuals to be able to make informed decisions about their bodies and their lives. The question is, how do we get there? And which I loved Dr. Ogden's presentation on, vulnerabilities to strength, using this moment as this vulnerable moment to essentially collectively come together to demand action. Next slide, please. So now understanding the state of affairs and the context in which we're working in, going to get to the gender and UHC perspective soon, but also understanding how does gender intersect with health? And we all kind of here understand that, but it's good to kind of just put it on paper and really think through on this so that we can align. Gender, a social determinant of health, it impacts health outcomes, and intersecting gender inequalities in turn put people's health and well-being at risk. So, for example, women, girls, gender diverse people in particular bear a disproportionate share of the disease burden because they experience unique health risks that are associated with their gender. So, for example, in the context of sexual and reproductive health, complications arise that are specific to the experience of pregnancy, childbirth, menopause, menstruation, etc. Especially for adolescent girls, who face unique health risks due to their age and their biology. For example, early pregnancy results in serious complications and poor obstetric complications like preterm delivery, low birth weight, preeclampsia, postpartum hemorrhage, anemia, as well as higher rates of infant and maternal morbidity. Social norms that shape our experiences based on our gender also have an impact on the disease burden. Girls and women, especially adolescent girls, face greater challenges to receive care and information about their health. And then not being able to access those services and information in itself increases the likelihood of contracting STIs and becoming pregnant, especially at a young age, and this increases their disease burden. GBV, gender-based violence, is also a main driver of the disease burden as well, where a quarter of adolescent girls who have been in a relationship are subjected to physical or sexual gender-based violence by an intimate partner in their lifetime. Next slide, please. So now we get to the conversation about gender responsive universal health coverage. Why universal health coverage? Why are we talking about it? It is a main pillar with the World Health Organization. And why gender responsive UHC? Why are we investing and pushing for this as a response to these challenges that we're facing? Taking a step back, universal health coverage means that people have access to the full range of quality health services they need, when and where they need them, and without financial hardship. And we have to understand and remind ourselves that universal health coverage is essential to achieving the SDGs, specifically SDG 3 and 5, and also that it's a critical aspect of recognizing and progressively achieving the right to health and the right to SRH, the sexual and reproductive health. Now, what is gender responsive universal health coverage? It's interesting because I feel like we talk about it in two different parts, but they're actually it's all the same, right? Gender responsive UHC means that health systems are designed and implemented to address the health needs of all genders, ensuring equitable access for all. So it's it's embedded within that universal health coverage definition. Gender responsive health systems are crucial to reducing the disease burden amongst women. That it means that health systems are designed and implemented that they are addressing all needs of women, girls, and gender diverse people. Essentially meaning, what does a gender responsive health system look like? It tailors services to unique needs. It addresses barriers to care. It promotes equality. These systems then go on to help and prevent and manage disease more effectively, which goes on to improve health outcomes, promoting equity across populations. So attention must essentially be paid to the unique differences that women, girls, and gender diverse people face in terms of their health risks, their health status, and access to services. But also, again, to note that universal health coverage has to be gender responsive to be realized. Gender equality, including SRHR especially, includes the equal rights and equitable access to health services for all individuals and all their diversity. It is fundamental to achieve UHC. SRHR in particular is a non-negotiable to universal health coverage and global health, and this is what needs to be communicated and socialized essentially. Next slide, please. So where do we go from here? What do we do? How do we address these challenges? And I don't have all the answers, of course, but I can come in from the Women Deliver perspective and from an advocacy perspective, given our experience, working in different global spaces and having a multi-stakeholder approach in our ways of working. First, that health systems should be reoriented using a primary healthcare approach. Primary healthcare approach is the most inclusive, cost-effective, and efficient approach to reaching the most vulnerable and marginalized communities. And it delivers the full range of quality services that people need. And so looking at gender-responsive primary healthcare systems and primary healthcare approach that includes the SRH services and SRHR. We also need to hold member states accountable. They have a responsibility in international law to progressively uphold the right to health and the right to SRHR. They have made commitments on universal health coverage. There are high-level meetings that happen every 3 years on universal health coverage, among other global health issues. And these are the spaces in which member states are asked to report out on their progress. And the next high-level meeting in 2027 will focus more on accountability. And so really talk, giving member states a chance to talk about how they have achieved their UHC commitments or what they'll do to achieve it, but really holding member states accountable and ensuring also that sexual and reproductive health is part of UHC and part of their national health plans. What's discussed in the UHC context at the global level, it goes on to impact national level policies and national level health plans as well. We need to invest and uphold in multilateral systems and frameworks. These systems are not perfect. They are not, but they're under attack by anti-rights actors and anti-gender movements. And these are the spaces in which we have to work in. As I mentioned before, just in my previous point, is that what is discussed, at the global level, whether it's through the Beijing Declaration or it's through, the CPD or it's at the WHA with the WHO. These conversations have an impact on the standards that we make and the norms that we create on gender responsive health systems and gender equality. We need to also ensure that we're taking an intergenerational approach to decision making, making sure that young people and adolescents are part of decision making, full stop. They have unique experiences, they have unique perspectives that have to inform policies and health systems going forward. That's the only way that this can be inclusive and equitable for everybody. But not only are they receiving care, they are the future health workforce as well. They go on to provide care. And so really protecting and supporting young health workers as well, and making sure that they're part of decision making, making sure that they're at the table, making sure that they are also they have a chance to hold member states accountable, that they are contributing to these multilateral conversations. And then lastly, but of course not an exhaustive list, but lastly, we need evidence-based, science-backed narratives, progressive narratives to socialize what gender responsive health systems are. It needs to be normalized. And how gender responsive health systems address the disease burden for everybody, especially the most marginalized. I've mentioned the anti-rights and the anti-gender movements. And this is exactly where I think this particular point kind of drives home at. We need to counter a lot of the narratives, the negative narratives on gender and SRHR that is being put out there, not just in multilateral conversations and systems and in these kinds of spaces, but on social media, for example, in algorithms, making sure that we're countering that, but we're countering it with science, we're countering it with evidence, with decades-long research that, make the case for gender responsive healthcare and health systems. So there's a lot to do, but we need to come together, I think. I guess as my last point, we need to come together across sectors, across expertise, across age, in intergenerational sense, to align on how we move forward, to ensure that we push for evidence-based and science-based progressive narratives on gender equality, so that we can make progress towards the goals that we have made towards global health. But I'll end there, and I just wanted to say thank you so much for allowing me to deliver this keynote address, and I'm very excited for the rest of the panel. Thank you. Over to you, Ella.
Great. Thank you so much for that. So let's move right on ahead into our panel discussion. So we have 5 panelists joining us today, and I would love to introduce them, and then we can get started with some questions. So joining us on the panel, we have Dr. Irene Anine. She is the Chief Science Officer at the Society for Women's Health and Research, where she leads efforts to advance science that better reflects the needs of women and girls. She organizes expert working groups to address gaps in women's healthcare and translates their findings into science-driven, patient-focused policy solutions. We also have Debanjana Chowdhury, the Executive Director of the Women's Global Network for Reproductive Rights, a key voice in grassroots advocacy for sexual health and reproductive rights. She's a gender activist who has over 2 decades of experience in the gender rights and justice movements. In her current capacity, she works in cross-movement building, mobilization for solidarity, and she actively engages in intersectional conversations around disability rights, sexual health and reproductive rights, and climate justice. She currently leads a dynamic team of activists in the Global South. Next, we have Dr. Katie Davis, an interdisciplinary postdoctoral research associate and social scientist at the Liverpool School of Tropical Medicine, whose work focuses on issues of gender, inequity, and power in relation to global health and the environment, including working with antimicrobial resistance, climate change, conflict, and displacement. Next, we have Dr. Rubina Sohail, an OBGYN and professor representing the International Federation of Gynecology and Obstetrics, or FIGO, bringing clinical expertise and global advocacy for maternal care and infectious disease care. Her research is focused on sexual and reproductive health and education, as well as gender equity and care in crisis and humanitarian settings. And lastly, but not least, we have Dr. Michelle Rem from the Global Fund, where she contributes to strategy on health system strengthening, healthcare financing, and equitable access to care. She's worked in global health for over 18 years at the intersection of health financing and the social determinants of health, gender, and intersectional equity. She currently works in the Community Rights and Gender Department at the Global Fund, where she is the manager of the Thematic Cluster for Human Rights, Gender, and Health Equity. So a very warm welcome to all of our panelists today. If you feel comfortable turning your camera on, please do so. And each panelist will offer reflections on key challenges and potential solutions for advancing gender equity within the context of infectious disease and global health. And I'm looking forward to a very thought-provoking discussion. So I would like to open the floor for discussion with 2 questions to begin with. Any panelist is free to answer if they feel that they have something to share. However, I do ask that you keep your responses to about 1 to 2 minutes so that we have room for all the panelists to speak with some later questions. So my first 2 questions for the panel are, from your perspective, what are the most critical gender-specific challenges in infectious disease prevention or treatment and care that remained overlooked in global health policies? And then my second question is, can you share an example of a successful community-level intervention or other intervention in your field that has reduced infectious disease risk among women by addressing some of the social determinants that we mentioned? So I'd love to open the floor up to anyone who would like to share.
Well, I guess I can open. Thank you so much for having me. It's this is a very important conversation, and glad to participate with it. Participate on behalf of the Society for Women's Health Research. And I would, for the first question, I think a addressing critical gender-specific challenges, often what we found is this trickle-down investment in women's health and gender, in addressing gender health gaps from the global to the local context. You know, we have global initiatives, we have work groups, they provide resources and overarching strategies, but these opportunities have to be tailored at the local population and the community level, being very specific to the group that that you're meaning to serve. And so when I say investment, it's not just dollars, it's the time, the resources, and the patience that it will take to see this long-term development goal achieved. And I think a lot of times, like, we have this initiative and it's going to be a year or two and it drops off. But when we're talking about global health, we have to invest in this long-term growth and development and change that you're not necessarily going to see in 1 year or 5 years or even 10 years. And to the keynote speakers, wonderful job in setting the stage. And to that, I'd add social determinants of health are really important to address. And when we do that, we will say, oh, it's transportation. We'll say it's education. We use these broad sweeping terms. But again, they need to be translated into the local context to maximize effectiveness. So for example, transportation, yes, that's a challenge for many women, but it's very different in a village in Kogi State versus the bustling metropolitan of Lagos versus a more spread out federal capital of Abuja. These are all different contexts in locations in Nigeria, still within the same region. So they affect a small portion of the country geographically, but they're very diverse. And so we have to really look at and take the time to translate all these different opportunities and these different initiatives into what it really looks like for those individual communities.
Absolutely. Definitely very important not to take a one-size-fits-all approach when you're trying to address gender equity. Dr. Davis, do you have something to add?
Yes, just to add to that, I just wanted to, really emphasize that the importance of the context specific. So currently I'm working as part of the Gear Up Consortium, which is a Fleming Fund regional grant that supports the mainstreaming of intersectional gender equity lens within antimicrobial resistance work. And in our work, we've found that inequitable power relations, particularly that relate to gender norms, can influence diverse aspects of people's experiences of AMR, both from exposure, susceptibility to infection, experience of seeking care, ability to seek care, to the socioeconomic impacts of experiencing antimicrobial resistance and resistant infections. And these include many of the factors that Kinza described earlier, complex social factors that we think of as the social determinants of health, particularly due to gendered barriers to accessing healthcare and health services. Gender can affect who is represented in formal health surveillance data and information about resistant infections as well. So this is all really context specific and complex, with various exposures affecting different people and different groups in complex and intersecting ways. But also to highlight that research has identified that women often play a really key role as stewards within antimicrobial resistance and in the use of antibiotics, whether that's as those responsible for care work in the household, or responsible for care of animals, or those working in frontline health roles, for example. So I think sometimes these sometimes more invisible roles can be quite overlooked, and the power that those hold, and in specific contexts, is so important to keep in mind. And then also, if I can add a sort of related challenge, I suppose, particularly when we think about antimicrobial resistance, there's a really significant lack of data that's disaggregated by gender and equity indicators. So it's a challenge to sort of piece together those complexities at a local level, and often the data isn't community based. So we still find there's often a significant focus on within interventions in antimicrobial resistance that focus on behaviour and education. And while that is important, really understanding these community level social determinants of health and how they affect people's experiences of resistant infections and experiences of seeking care is really important. And And while this kind of shift to understanding the social drivers of disease has happened, you know, in some contexts and in some areas, like Jessica was describing with HIV, it seems in some ways slower to happen within antimicrobial resistance than with some other infections. So yes, I'll stop there, but thank you.
Yeah, thank you so much. Dimanjana, I think you were next. Who wanted to share something?
Thank you so much. Just to add to what everyone is saying, and first of all, good evening, everyone from my part of the world. I am so glad to be here and to hear from the fantastic panelists and the keynote speakers. A little bit about WGNRR. Women's Global Network for Reproductive Rights is a global South NGO. We work with partners across various continents and contexts, and they advocate for sexual and reproductive health and rights for all. As you've already mentioned, movement building, collective action, advocacy are some of the key areas in capacity building that we are working on. Having said that, we work in Global South, and in almost 90% of our communities we work with, the spaces we work in, son preference is prevalent, something that Katie also did share a little bit about the gendered roles, which means that girls and women are treated as a secondary citizen. They are not prioritized for health access, diagnosis, and often they are an afterthought. And we have seen it clearly during the pandemic in the communities that we work, in the countries that we work in, that most of the policies, most of the way the healthcare that was being accessed or healthcare that was available was extremely tone deaf. It was gender insensitive. Most of the national healthcare policies were not even considering the diversities. They were not considering the vulnerabilities of women and girls or persons living with HIV, LGBTQI. So I want to draw our attention. I know we are talking about infectious diseases, but I also want to draw our attention to reproductive health and related concerns like menopause, PCOD. These are definitely not prioritized at all in Global South. I can say in the Asia Pacific and the Africa context as well that we say information is not there. So how do we, mitigate it? There is a need for information. There's a need for awareness. Apart from the access part of it, there is also a need part of it. And most of the times, women and girls and persons with diverse genders, they suffer in silence because they do not know where to go. They do not know how to access these healthcare services. And many a times we have seen that their voices are completely ignored, unheard of during prevention and care. And under the SRHR umbrella, we work with people living with HIVs. We also work with a lot of people with STIs with very little information, very little access to dignified quality of care. And we see the difference when it is a cisgendered man who's accessing care versus a cisgendered woman and a person with who's a non-binary person and identifies as anywhere in the spectrum. So it just exasperates, and we really need to identify all these nuances. We need to be careful that, how we are tailoring our healthcare work, and even evidence that is available at a very global level often do not have voices from all these areas. That there are, even if there are local voices, the local voices are not as diverse as we would want to be, or as diverse to reflect the population or the needs of the community. I stop here. Thank you.
Thank you very much. And then Michelle, I think you wanted to add something?
Yes, thank you. And also, hello, everyone. And really thanks for having me and for the privilege of being on this panel with such inspiring colleagues. I think so much has been said, but I just wanted to also highlight what others have highlighted, that one of the critical challenges that tends to be overlooked is really this aspect of power, agency, and control, or rather lack thereof. We tend to be much more comfortable still to stay within our sort of biomedical behavioral interventions that put the onus on individuals, and it's a challenge to work more on structural interventions that address power and social determinants of health. And these are often viewed as, at least in my experience, as these contextual factors, things that cannot be changed, that are beyond the health sector's remit, at least. And as Kenza was saying, that we need to address these inequalities. It will be essential to address them to achieve health goals and to achieve UHC. And the same is true for infectious disease control programs that are trying to prevent transmission, trying to prevent morbidity and mortality by ensuring access to prevention and treatment services. Yet we know that many women still cannot access health services without spousal consent. nearly half of women cannot make their own decisions about having sex, contraceptive use, and seeking reproductive health care for themselves. We know others have mentioned intimate partner violence. It's widespread, it starts young. And in settings in Eastern and Central Africa, for example, where we also have, of course, high HIV and malaria burdens, past year violence is as high as 24% and 32%. So we know that's further associated with vulnerabilities to HIV, lower uptake of ANC, of elimination of vertical transmission services. And we know that that has, direct consequences for these infectious disease programs where exposure to IPVs means that women are more than 1.6 times more likely to become infected with HIV, and pediatric infections are also higher. So I think for a lot of that then is when within a health sector logic is sort of this is beyond what we can do, but actually there is a whole evidence base out there of interventions that have been found to be effective at transforming these power dynamics, at advancing women's agency and control. They are complex interventions at times, yes, but these are not unmodifiable factors. And so just wanted to maybe speak a little bit to your question about, examples of community level interventions. There are several, and some of them, many of us have heard about, Sasa in Uganda or Indoshakira in Rwanda, but have found impacts of working with couples to reframe power relations and working within communities to change social gender norms. That has had direct impacts, more than 50% reductions on the experience and perpetration of violence within timeframes of programs. So within 2 years, because what you often hear is this is going to take a very long time. It's not possible to do it within programmatic timeframes. But we have evidence that we can build on, and a lot of practice-based experience from communities and society as well that has shown how this can be done and how we can do this effectively. So I'll just stop there. I think it's always important to remember that we know there's something we can do about these factors, and the health as health funders and working at the Global Fund, but actors within the health space, there's a lot more we can contribute to in this space. Thank you.
Yeah, absolutely. Thank you so much for that. Right. So if no one has anything else to add for these two questions, I would love to move on to some specific questions tailored to our panelists. So let me just put these back up. All right. So first, I would like to ask Dr. Anine, so historically, we know that medical research has often overlooked gender differences. In your experience as the Chief Science Officer, where have we made progress, and what areas still need more attention related to infectious disease research?
Well, yes, we have. That's the short answer. In the U.S. over the last 50 years, for example, the FDA actively discouraged women of childbearing age from being included in medical research. We understand the challenges. They make sense, but in research, we're here to ask the difficult questions and to navigate finding these solutions. And so I guess one really strong win was the NIH Revitalization Act in 1993. It mandated the inclusion of women in medical research and research for vertebrae and human studies. And also following up with that in the early 2000s was the SABV policy, or Sex as a Biological Variable policy, that was instituted by NIH, who funds majority of our biomedical research in the US. And it put a stronger mandate on making sure that we not only include and look at sex and gender, but also to disseminate the data and do the analysis there. So these have been very helpful in making sure that women are at the table. I would say one of the initial challenges that we really need to communicate is that analysis by sex and gender, and making sure that we just don't have 40% women, but we're actually looking at the aggregate data and the disaggregated data to determine whether there is a difference, and if there is not a difference, communicating that evidence as well. And what this looks like, or rather the challenge that we most recently saw was during the COVID vaccine development. The early studies did not include pregnant and lactating populations. And so I know we're on the Infectious Disease Alliance program, but even if you regardless of whether you are, for the vaccine or against the vaccine, we didn't do the studies. And so women were not informed. They did not have the knowledge. Their practitioners were not able to help them make informed decisions about their health. And that is the scariness and the vulnerability that we are left with when we haven't included women, different populations of women, understanding that. Into our conversation earlier, part of that really requires looking seriously at the social determinants of health, because it's not just for implementation, but to make sure that we can recruit and retain these women in the studies that are necessary. We also have to look at these social determinants to make sure that we are being as inclusive as possible, not just because it's the thing to do, but if we truly want to help these populations, we have to make sure that we do whatever we need to do to incorporate them, invest in them, and then make sure we have solutions for them.
Absolutely. Thank you so much for that answer. All right, next, I would like to ask Debanjana, how have the recent global health funding cuts impacted your work in the Global South? And I guess briefly, how do you see this impacting infectious disease risk for women and girls in the future? I know we kind of touched on that a little bit before, but I'd love to hear in your work, how are you experiencing this?
Sorry. Thank you so much for that question. And, it's something that the entire Global South, we are impacted. We are definitely impacted. Now, with such fund cuts, which Kinza had also mentioned, it's going to roll back healthcare for women and girls by decades. It would mean that women and girls would not have access to contraceptives. They wouldn't have access to awareness and information. We wouldn't be able to build the capacities of a lot of individuals and activists on ground. Women human rights defenders would be further cornered. And it would also mean that safe abortion rights will be highly it will be highly stigmatized. We are working in such settings where it is a stigma. It is highly stigmatized. Talking about SRHR, it is extremely tabooized in most of the countries that we are working in. There are religious contexts, then there are denials, opposition, the growing opposition that is, active in all the countries that we work. And I'm going to share the example of Philippines particularly. Philippines not just has religious, systemic opposition, but it also has opposition from the providers. So in Philippines, it's one of those countries in Asia Pacific where abortion is completely criminalized, and one can be, can face imprisonment up to 6 years. And when such fund cuts happen, it means that the access to information, access to telemedicine is also jeopardized. She was probably getting some access in post-abortion care through the post-abortion site, though that's also equally risky because a provider may report out to her and may call out her and report her to the authorities that a person has come for, and it looks like an induced abortion. During post-abortion care, a provider may do that. But nonetheless, even that access is not available to her anymore. Telemedicine, which makes life easier for an abortion seeker, will not be available to this person. And the thing is that we all, again, a few of my panelists have already shared about how a caregiver's role is glorified. Like, women are glorified as caregivers, they're put on a pedestal, and it is an expectation. They will put the family first before they access care. So they will continue to suffer in silence. And what will happen is that activists are going to be threatened. And we are already seeing that in a lot of country contexts that we are working in Asia, where we are seeing women human rights defenders are getting calls, they are being held up by authorities, they have to move countries, or they have to just lay low to avoid all the excesses that is happening. And but again, everything has a solution, and we are planning our mitigation strategies, because this is a lived reality, and we are bracing for more. Not just the USAID funding cuts, but also funding cuts and excesses from different governments, like the Dutch government. They have completely moved away from gender. They do not want to support gender policies and programs anymore. Again, Philippines is that one country where the government of Netherlands used to be very gender-aligned SRHR focus. So most of the programs were being funded by the government of Netherlands, and now that's not going to happen. It'll mean there'll be no access, there'll be no information, and also there'll be rollback on medicines like available miso. It'll not be available. There'll be rollbacks. There'll be rollback in the supply chain. We'll see everything being affected. As WJNRR, we are already working on mitigation, and some of our mitigation strategies are increased awareness, collective movement building, capacity building of providers. So we do a lot of VCAT trainings for providers in South Asia and East Asia, because we find that even in South Asia, in countries like India, where abortion is legal and it is legal up to a certain extent, there is high provider denial. So we continue to work on value clarifications. We continue with our advocacy work for gender-sensitive policies. We consider different needs, experience, and barriers that are faced by young people, including the boys, because they are also facing equally the challenges. And we are trying to integrate gender analysis in global health policies. We are working at international global health spaces like the CSW, like the CPT. We are working with at the national governments. We are informing the legislators that they need to, if they have ratified CEDAW, then they need to uphold what they have ratified too. They need to walk the talk. We are working on UPRs and making space for civil society voices in different, national and regional spaces that are there. Back to you.
Great, thank you so much for that answer. All right, next I would like to ask Dr. Davis a question. I'm interested in your work on climate crises, and based in your experience and your research, how can intersectionality inform more inclusive infectious disease interventions within the context of climate crises?
Thank you for the question. Yeah, so I mean, as I'm sure many here are aware, intersectionality means, having an intersectional lens means understanding how different social dimensions and axes of inequality and power relations intersect to create unique and specific experiences. And as we've been discussing, this means that context is really key, and people's experiences will be diverse and very much tied into ongoing experiences and crises such as displacement, climate change, conflict. But I think what intersectionality also allows us to do is to both look at these specific and unique experiences, but to be able to tie these experiences to the wider systems and power structures and inequities that we've been discussing, and that are very much at the root causes of ill health, infectious disease, but health more widely, across diverse contexts, and to think about acting on these in a cross-sectoral and integrated way. And I think this really requires political accountability, as Jessica made clear earlier, but also something that I think is clear just from experiences working across infectious disease and specifically antimicrobial resistance, and also contexts of climate change and conflict and displacement, is that actually these deeper root causes and power relations that we find driving infectious disease are largely the same root causes and structures that create risk in the context of climate change and the context of displacement, and how each of these obviously very much overlapping crises. So bearing that in mind, thinking about these not necessarily as distinct overlapping crises, but crises that often stem from very much the same sorts of processes. In antimicrobial resistance, we look at diverse ways in which power relations affect people's exposure to resistant infections and their ability to access health services, as I've described. And I think also just thinking about how it contributes to burden of disease and spread of infection, and the growing recognition of the importance of this and the lack of data. So really coming back to this question of data and disaggregation of data that others have raised, thinking about trying to develop data that is intersectional, that allows not just the collection, but the nuanced analysis of these equity indicators to allow global trends and links to be explored, but also unique context-specific trends to emerge, and thinking also about how that data can be community-led and community-owned, so that the architectures of data collection and creation, there's more power balance there, and there aren't these sort of hierarchies of the type of data and knowledge that are privileged in infectious disease research, and thinking about complementing statistical data with nuanced qualitative data, and often that does really need to be context specific and community based. So I think an intersectional lens can really put an emphasis on the complexity, while also really drawing us back to thinking about these deep power structures and how they intersect, and the common root causes of many of these challenges.
Great, thank you so much for that. Okay, next, speaking to Michelle from the Global Fund, I would like to ask you, with shifting global health financing trends, in your opinion, how do you think we can ensure long-term financial support for gender-sensitive or gender-transformative health interventions or programs?
Thank you. So I think to ensure and to keep these gender-responsive services programs on the agenda and prioritized for funding, we really need to keep the focus on access to services and on disease outcomes. And I think there's a bit of a tendency to focus only on availability, and if we keep focusing on access and flagging that availability is not enough, it will not get us to acceptable, accessible, quality services. If we keep that focus, then we would be able to keep the framing and attention to addressing gender-related vulnerabilities and barriers. And so within that, really keeping this science and evidence-based approach to achieving these outcomes. And I think, as Jessica highlighted earlier on, I also feel health systems should be taking more responsibility to address gender biases and vulnerabilities within their building blocks, within service delivery. I think there's a lot more that can be done within this space, both to reduce barriers, but also to transform gender norms. I think we all know how influential and the big critical role that health systems and health institutions play in many settings, and can be norm setting and can perpetuate or transform norms. And so I really think that this is an aspect where we need to be, that needs to be taken on, and there need to be resources behind that to make that possible. So building competencies at scale for respectful care for women and girls in all their diversity that's free from stigma and discrimination, which can be very proactively done through training, supervision, quality improvement models, but also then linking that to strengthening institutional as well as social accountability mechanisms that are led by communities to make sure that this type of person-centered, gender-responsive care is in fact being provided. And this is where communities, civil society organizations are really central to advancing these priorities, and the community leadership that they provide and the community engagement needs to be resourced. And I think that's something for global health financing also to keep in mind. And that also includes investments in the safety and security of community-led organizations and feminist groups, which is something the Global Fund has been very committed to, particularly in the context of the anti-gender and anti-rights movements, where we've seen escalations of violence against various groups. And one other aspect I think is also important to ensure continued support to gender-responsive approaches is that we need to the parallel disease-specific funding channels that have been dominant in many settings have created silos, and in some settings have disincentivized a sort of integrated multi-disease and multi-sectoral approach and investments to tackling some of these upstream social and gender determinants of health. And so for multi-sectoral interventions in particular, I think health financing and health decision makers need to recognize the roles that they can play in strengthening linkages with programs and investments that are beyond the health sector to increase how those contribute to health outcomes. And I think others have spoken to this as well. And so using health resources strategically to catalyze and incentivize those interventions that yield impacts that can address gendered vulnerabilities in general, but also in terms of service access would be some approaches to consider. Thank you.
Yeah, thank you so much. And then I did have a question for Dr. Sohail, but I did not see that she has joined the call. If you're here, speak up, but if not, then we can move right on. Thank you so much to all of our panelists for your insights and your perspectives. I think that was a really great discussion, and I really enjoy hearing all the different aspects and recommendations that you bring from your respective fields. We have about 6 minutes for some questions from the attendees. If anyone has any questions for our panelists or our two key speakers, feel free to raise your hand or type them in the chat, and we would love to get those answered. Yeah, Dr. Davis.
If I may, I have a question for Jessica actually. I was just thinking about your presentation and the links you drew from the experiences of HIV and kind of having community-led and community-driven initiative and action and change within infectious disease. And thinking about other areas of infectious disease work, you know, often I think in different infectious diseases and different areas of health can be addressed often in silos, which isn't necessarily helpful. But I'd just be really curious to hear if you had any thoughts on learnings from the experience of really mobilizing community-led change within HIV, and how, if there are any particular lessons that you would draw out that might be worth applying to other areas of infectious disease. So for example, in antimicrobial resistance, I think that's something that we discuss as very much something that's needed.
Yeah, great question. And I think about this a lot, not just in relation to health, actually, but sort of drawing on the experience and success. I mean, HIV was just, I mean, obviously not a complete success, but, you know, just has a lot of valuable lessons for a lot of other areas. I think, you know, this also happened in tuberculosis, as I sort of alluded to, the sort of the rise of community activism around getting access to the drugs closer, you know, so people didn't have to walk to the health care center just to get their drugs every day. And so there were some big changes there. I think that piece of community activism is critical. But I think the thing about HIV and maybe TB that's different than some other diseases is that they affect everyone, you know. And I think so. I think where you can build community awareness of the importance of microbial resistance, you know, and get people from different civil society organizations, education, you know, within schools and so forth, to be talking and thinking. You're building a coalition, you're building energy. But you also have to, like, as Michelle mentioned, I mean, those movements have to be resourced and not done on the back of people's goodwill only. So, but yeah, I mean, I think, you know, just my head's in coalition right now, and so that's what I'm thinking of. But I'll noodle on it. If I come up with anything else, I'll let you know.
Thank you. Yeah, really key point.
Great. So does anyone else have any more questions? Feel free to put them in the chat. Yeah, Carl?
Yes, thank you. My question is from Dr. Katie Davis. Given your work with the Fear of Consortium, how can incorporating an intersectional gender equality lens into AMR surveillance enhance our understanding of the issue and inform more effective policies?
Yeah, thank you for the question. I mean, it's something which we're very much thinking through a lot, and particularly thinking about within antimicrobial resistance, a lot of the data that we have, and a lot of this comes from surveillance data as well, is it, you know, we meet a lot of the challenges that we've discussed already around, you know, it being there in the first place, the quality of the data, whether it's broken down by what we would think of as like quite key equity indicators, and thinking about trying to bring an intersectional lens into thinking about data is, I suppose, such is a really key way forwards. But it's also, so it's both about thinking about those indicators, thinking about being able to facilitate the more complex and nuanced analyses that we've described, but it's also thinking about the challenges and the biases in that data. So, for example, resistance data is often collected at facility level, and often those facilities are hospitals. And there's very, very little collection of data on resistant infections that goes beyond hospitals and facilities. So, given what we know about health and about the barriers to people accessing health systems and health services and diagnostics in the first place, that means that really that data is going to be only the tip of the iceberg in terms of really what's happening at community level with infectious disease and particularly antimicrobial resistance. And then even with antimicrobial resistance, that's obviously diverse, different infections and types of infectious disease as well. So really being able to understand all of that is a real challenge. And so I think the key with intersectionality is thinking about how do we bring equity considerations into the data that we have and promote increased collection of what we've, these indicators that will allow an intersectional analysis, while also thinking beyond the systems of data collection that exist. How can we expand, the way in which the architecture of infectious disease surveillance, particularly resistant infection surveillance, to be both thinking beyond facility level and hospitals, to be sensitive to community level processes and infections, but also led by communities, so that the power systems that are inherent in those disease surveillance systems are interrogated and shifted to some degree as well. So thinking critically about what the data can tell us inherently, what's there to to draw out, and what actually the limits are and where we need to expand. So I think having an intersectional lens means thinking about all of this collectively, trying to get value from the data we have, while also pushing beyond the limits that we already have at the moment as well.
Great. Thank you so much for your question, Carl, and for your response, Dr. Davis. I think that is about all the time we have for questions. So just to wrap up briefly, let's see. So as we conclude this discussion, I'd like to share the Infectious Disease Alliance's call to action related to gender equality and health that's on our website. I will share the link in the chat. And the Infectious Disease Alliance will continue its work in supporting research, innovation, and advocacy to advance gender equity. We really encourage all the attendees and panelists and speakers today to stay connected, participate in future events, and take action in your own communities related to community-led initiatives aiming to advance gender equality and health. And I would like to thank everyone for your time, your dedication, and your commitment to global health. Thank you for attending today, and a sincere thank you to all of our participants. We look forward to collaborating with many of you in the future, and I hope you have a great rest of your morning or evening.